Hi, welcome to our online series on knowledge translation in neurophysiotherapy. As many of you know that we have started this new project, a very ambitious project to promote knowledge translation in neurophysiotherapy. So as part of that effort, this is our online series, and this is the first episode in that online series where I'm going to do a case presentation, evidence-based case presentation. In this presentation, my goal is to describe the process by which I have attempted to solve a clinical problem using steps of evidence-based practice. Now, this is the problem, as you can see in the video. A patient with stroke is having difficulty in sitting on a low stool, and also the patient is not able to sit on the floor. So this is the problem that he's having, right? So what I right. So what I did was, okay, this is the problem as a clinician that we encountered. So how you can apply evidence into practice, that how you can apply the existing knowledge and in terms of solving this problem. Now, conventionally, such problems have been addressed with exercises, strengthening exercises that are targeted at lower limb muscles. So mostly patients were asked to do quadriceps exercises and some other lower limb exercises, just bridging and so on. This is a traditional, conventional practice. So I thought, okay, should I give this treatment, or is there any better treatment available? Can the patient's outcome, such as sitting on the floor, can be improved by any other treatment? So that is the problem I, as a clinician, has encountered. And in the remaining part of presentation, I'm going to explain how I approach this problem using evidence-based practice steps. Before getting into it, I'll give you the basics, some fundamentals about this patient. That is, a patient is a 55-year-old male. He's retired and he's literate, and he's upper middle class. And he's married. He lives with family in a rural Gujarati society. And he lived in England for about 20 years. He was working there, and now, like 3-4 years back, he has returned to India, after which he has had this episode of stroke. And some disease related characteristic. Currently the patient is in a chronic stage and more than 1 year since he had a stroke, and his disability severity, slight slip disability, the modified Rankin scale score is 2. He's able to walk without others support, and many activities he can do, but still he needs assistance in some of the area. And ambulation status is an independent community ambulator, and he drives a scooter for short distance travel. So these are all some basic demographic characteristics about his status that will help you to grasp an idea of what is his current status. And the problem, as I have just described, the patient is able to do sit to stand from a standard chair. He can do on his own, but he's unable to adapt to a different one, such as sitting on a low stool or low chair, and which is leading to limited participation. Now, how this is actually affecting his daily life is that the patient has, say, he lives in a rural community, and he has a bed that is of a low height, right? And also when he goes out in the evening, he spends time talking to his friend, going out, meeting friends and so on. In the place where he's meeting, that they have a low platform in which they sit and talk, and now he's unable to sit on there, so he needed another chair. He's not able to sit with his friends in a low chair. So at times he tends to avoid such circumstances wherever this is necessary. So he's sort of interested in if he can do that, his participation can get better. And there are certain other circumstances, such as taking bath and so on, that he prefers sitting on the floor and do it. And in many other circumstances, such as if he has to go to a temple and attend a prayer and so on. He's required to do sitting on the floor. So presently he's been avoiding these circumstances because he's unable to sit on the floor. So the patient wants to improve on it, right? So how can we go in addressing this problem? As I said, to integrate evidence in practice, these 5 steps has been proposed, and it's a pretty straightforward step. So I'm going to explain how each step has been followed in order to decide what treatment would be appropriate for the patient to achieve the outcome, that is sitting on the floor or sitting on a low stool. So in the 5-step process that is suggested in evidence-based practice, the first step is ask, second is access, third is appraise, and fourth is apply, and fifth is assess. Now the first step, that is ask, means we need to formulate a answerable clinical question. Now in evidence-based practice, this is an important step because this step helps us to clearly define patient problem and also the expected outcome within the patient's disease context, that is specifics about patient's disease status. We need to formulate this question. This PICO is, that is population intervention comparison and outcomes, is a useful format that helps us to formulate a more focused question. So I've given in terms of how this can be used. As you can see, the population or patient, I have added the patient information that are clinically relevant to the outcome. So it's a chronic stroke and he has mild disability, and I wanted to see the common treatment, this conventional approach that is given, which is impairment oriented treatment. Usually, like I mentioned before, it usually involves giving some strength exercises, isolated movements, or having a weight cuff, or doing bridging activities or stepping activities, so on, to improve lower limb strength, and therefore from there it is expected that improvement in lower limb strength will lead to improvement in sit to stand, right? That's a conventional practice. Now I wanted to see whether is there a better treatment available. Now one of the in the recent years, like it's probably more than a decade, functional task oriented practice have gained a lot of attention. So I wanted to see whether a functional task oriented exercise in place of conventional treatment such as impairment or strength exercise, when it is given, will it improve the patient outcome or will it help to achieve the outcome? So that was the question. Basically, is one form of treatment, in this case functional task oriented exercise, is better, superior to a conventional treatment in producing the outcome, right? So this is how I used PICO format and formulated the question in such a way. So as I've just put some different colors to identify the each component of PICO. So you had this the experimental treatment or intervention, which we are interested functional task practice, and this is the comparison treatment. We compared that's a conventional treatment and asked whether this will improve or this will benefit patients benefit from functional task practice more than a non-task specific conventional training, right? So with this question we moved to a second step. In the second step, it involves us to tracking down the best evidence, right? So remember, the keyword is tracking down the best evidence, not any evidence or any research, right? So the best evidence is for a question which we have in this case, which is about effectiveness of a treatment. The best evidence is systematic reviews of randomized controlled trials which evaluated effectiveness of intervention, in this case specifically sit to stand. So I have searched for this question directly in Cochrane library, because currently Cochrane library is the resource for best available evidence specifically for questions related to effectiveness of on treatment. I guess most of us knows about it, but so just emphasize in case if someone is not familiar. So if you are having a question and this is the first place and the best available place we should be looking into. Right. So when I've searched, it's a fairly simple process. I've just typed sit to stand and stroke and exercise in stroke. Right. I have found these three major systematic reviews that are very much close to answering my question. The first one is the interventions for improving sit to stand ability following stroke. In this review they have it's more relevant. They have reviewed all interventions that are targeting sit to stand ability. And the second one is repetitive task training for improving functional ability after stroke, and in this review they have looked into all function, not just sit to stand. Now both of these reviews results supports that the current available evidence for functional task oriented practice is superior to a impairment oriented conventional treatment, right? So that is the overall evidence is pointing, and there is consistent evidence in the past 15 to 20 years, many studies that evaluated task oriented exercise especially for lower limb function found to be producing better results for patients. So that made me decide that okay, I should be giving task oriented exercise. But as you remember, the question that I have asked has a important component, that is outcome, that is whether this improves the sitting on the floor in a patient with stroke. uh, the systematic review doesn't specifically answer that question, because in this review if you look at the outcome is sit to stand from a chair, and also most of the participants or almost all of the participants in those study were already able to do sit to stand. So it has improved ability in terms of improving movement time and so on. The other study also reported similar, that is exercise found to be effective for different outcomes and improve sit to stand, but none of the studies actually addressed sitting on the floor or sitting on a low stool. So this is a problem, if I may say, which I've encountered, that evidence supports a particular exercise program but not specifically to the outcome, right? So I have went ahead. I'll explain how I've dealt with this problem when we are talking about application, right? So next, let us move on to the third stage, or the third step, that is Appraise. In the third step in evidence-based practice, it requires us to appraise, that is critically evaluate the evidence for its usefulness and validity. Now that means we have to read the study for risk of bias and look into these study results and see the effect size, and also overall consistency of the results and precision of the results and so on. And many of us find these terms to be rather technical. It requires quite a lot of amount of knowledge about research methodology, statistics, and so on. And this is the step many clinicians often were find threatening at times to go through it, because most of us have limited knowledge about what is a risk of bias and so on. But I did not actually go through this process, because I I have realized it is not I think it is not necessary to for a clinician to go through each study or go through the entire systematic review looking at risk of bias, because the Cochrane review itself is pre-appraised. It is already evaluated by authors using one of the strict standards, that is Cochrane standards for reviewing they've used. So it we don't really have to apprise it to that extent. So what we call it's a pre-appraised evidence. So Cochrane review is since it's already appraised, that's it's a sort of filtered information. Information is already filtered by authors, so they're basically doing this work for so that clinicians don't have to do it. So if this step was not actually that difficult, it's fairly straightforward, and Cochrane review has a pretty good standards, so we can move on to look into their results and conclusion. Not necessarily we have to appraise it. And I didn't spend much time on appraising. I just looked into the study results. I mean Cochrane review results, and they have a summary and so on. That's more than enough for me to make the decision. And the fourth step, the apply. So this step is where you apply evidence into practice. This is a key step and often misunderstood step. Misunderstood in the sense that many people assume that evidence-based practice means application of whatever the study result states. That if it states that one's treatment is effective and you will apply it. The answer is no. That is not evidence-based practice. Evidence-based practice up to the third step, you acquire evidence, you acquire the facts, and then you will interpret the facts within the context of your a clinician setting and the patient's values, right? And including the clinical experience. So this integration of these three is very critical to evidence-based practice. And the common misconception is not true. It's not just applying conclusion of a study author or a review author directly into practice. It doesn't work like that. Clinicians are expected to interpret keeping in mind their context and patient values. So there are few issues which I have found is relevant when I was integrating what are all things that I thought while deciding to integrate. Right. So here, first thing I thought, I've looked into feasibility, whether whatever exercise that they are recommending, is it feasible in my setting? I found it's fairly feasible that we have to do sit to stand in different chair height and so on. We have also made some arrangement for it. I'll explain later, right, when we discuss treatment. And acceptability of the intervention to the patient. Now, what I mean by acceptability here is because the patient is having chronic stroke, and the exercises with what they're recommending, I thought that this is going to take time, because chronic stroke, the adaptability is not going to come that quickly, right? So what I have explained to the patient that it's going to take like 6 to 8 weeks of duration minimum, that I've asked that you are expected to follow through the process of 6 to 8 weeks. Is it okay with you, right? So patient has consented that he is willing to continue with 6 to 8 weeks of an exercise program, which can be a bit exhausting also, because it's all that he has to do a lot of sit to stand, so it's going to be a little difficult. And also I've explained that the patient is likely to develop mild pain and fatigue because of the nature of exercise, and my past experience with this form of exercise also tells that this is common for patients to experience tiredness after days of exercise, and also knee pain is commonly reported. So I've told him that this is going to be there. And integration of clinical experience and skills, there are in different ways. I find that my clinical experience was useful while integrating the evidence. First and foremost important thing I think is that communication, how well I'm able to communicate to the patient about the benefits of this exercise, and also when he's struggling to do exercise, the suggestions that I can give in order to make it a little bit easier or a little bit with less effort. So these are all my content knowledge, content expertise, and communication was helping. Yeah, in communication, feedback, education, motivating the patient, reassuring the patient that you are feeling difficult today, but in a week or so it's going to get better, so focus on it. So these aspects were very critical for implementing, because implementing an exercise without integrating these things, it can be an exercise supported by evidence, but it might fail if we don't communicate it well, if you don't educate the patient. So it is very critical part of applying it. And in addition, in goal setting, I did some on the spot task modification, provided manual assistance, and also dosage determination and treatment progression, which I have decided. So all of it were very, very useful to apply in terms of final application of evidence into practice, right? So in the next part of the presentation, I'm going to show what all the treatment I have given and how I adapted it, and also the treatment dosage that I have decided, and so on, right? So this is the first exercises, if I may say. Patient, when we have already seen, he was finding it. I guess you remember. I guess you remember this tool, which he was finding it difficult to do, right? So once he was difficult to do, so the first thing what I have applied is I've asked him to get up from a slightly higher chair. Now the evidence doesn't specifically tell that you have to apply a higher chair, but it suggests that variability practice is important in general, not specific to sit to stand. But my but the biomechanics of sit to stand, if you look at, if we want to make the task easier, because this task is too difficult, so if you want to make this task easier, increasing the height of the chair is an important strategy which will make it easier. So I applied that context in here. So I thought I will increase the height and see if he's able to do better. So this chair is actually 16, I think it is 17 centimeter height. So we have used a chair that is 26 centimeter. This chair we have, it's a specially designed chair. Remember, we are talking about feasibility. In a specially designed in this sense that the height of this chair can be varied at 3 levels. It can be kept at 60, 26, 36, and 46 centimeter height. It can move. Additionally, we can also change the back support angle, and this arm support also can be removed. So it's specially designed. It's designed by one of my student, Miss Nisha Mahant. She designed it as part of her coursework and participating in an event. So we use that because it allows us to change the height. So let me show that when we have started practice with increased chair height, that is from 17 centimeter 26, and there is additional arm and back support that is provided in terms of modifying the functional task, because evidence suggests functional task practice is helpful, and the task needs to be modified to suit a patient's current ability. Let us see how the patient is performed. As you can see, the patient was still struggling to get up from it. He takes some arm support, right? But he still struggles to perform, right? So when I've looked into it, I thought, right, maybe the task require further modification to make it a little bit more doable without much exhausting effort. So I've modified the task again. In here, if you can see, right, there was I've given a pillow to further increase the height, because to make it easy, and also every time he was sitting, he was just falling onto the chair. It's a little bit hurting for him. So if I want him to repeat it for quite a few times, so it also provides a soft cushion. So then when, let us see this video, how he's doing. Right, when I've given this pillow under it, it slightly increases the height, right? So as you can see here, he was still not able to do it, right? He was having quite a few trouble, right? But we have continued to practice with that, and you will see when he's doing the second attempt, right? he still have a struggle, but eventually he manages to do. But this is during the first week. I'll show in the next video how he managed to do. But this one we stuck up with it because, as you could see, without arm support he was almost making it. So I decided this is challenging enough, so we should be doing. And we have the intensity or dosage of this is that we have I've asked like 15 times per set. We have repeated like 2 to 3 sets. Initially 8 to 10 times he did, but he quickly moved to 15 times. So uh, he practiced 15 sit to stand, and similarly like 3 sets or 2 sets sometimes mixed up. So on an average he was doing like 50 sit to stand during a session like this, right? So let me show what other efforts that are taken, right? So right, as we have seen next, we have also given this type of exercise where he is allowed to use some form of assistance. This is a low stool practice, right? But still with assistance, because previously he was not able to do without assistance. So he was just kept, I have just kept a chair over there. Remember I was talking about use of experience for modifying the task and all these and all. Again, it doesn't directly come from evidence, but I've it's clinical intuition, if you may say. Just put it, it was available over there. I thought if we can give him some support for him to do it, right? So this is another exercise, and each of these exercises he practiced a minimum of 15 repetitions for 2 to 3 sets, right? Okay, so after practicing these exercises on a regular basis, like almost 10 days he was practicing, right? And after 10 days, in the second week, at the end of second week, this is what he was able to do. Now as you can see, previously the same attempt he was struggling to make it. With the practice of 2 weeks, like up to 10 days, the patient was able to get up from the chair. And again, he's not able to get up from this stool, which was his original problem. But the task modification which we have done, which he was finding it difficult earlier, by repeated practice he has managed to do it. So it's this sort of one important milestone that he has achieved. But this is with this already uh, 26 centimeter, and probably another 5 centimeter added with this pillow, he was managed to do it. And we have continued practicing this, right? Sorry, this is another just a second, I'm having some trouble. Yes, this is as he has achieved this, that now you can see I'm giving a manual assistance, but here there is no pillow. We have removed the pillow and encouraged him to do sit to stand. Now with a manual assistance, actually I was giving a minimal assistance just to ensure that his foot is in place, and especially when he is going down, to give him support so that he doesn't fall. So a manual assistance was used to take him to the next level once he has achieved that, right? So at this level was so far the practice is completed. This patient care is currently ongoing. So maybe in my next presentation, once he achieves different goals, such as eventually when he achieves the independent sit to stand from low stool, I'll post another video explaining it. But this is how the evidence was implemented in practice. Evidence suggested sit to stand, task oriented practice improves sit to stand, but it didn't give specifically about sitting on the floor as outcome. But we have translated that evidence into practice, used the same principles of task oriented exercise, and adapted it to match patient's ability, and with appropriate dosage which is determined. like 10 to 15 repetitions for each exercises, and he was repeating it like 2 to 3 sets each exercise. So he does like 20-25 minutes of practice of all these things, right? So he has achieved one important milestone, that is in a slightly higher chair he was able to do it, which is previously not able to do, and he is continuing with this practice, and I'm hopeful that he will achieve, he's more likely to achieve the outcome. But this is how evidence from the evidence translated into practice. Right. The last step is assess. That is, we needed to evaluate if evidence-based practice doesn't end at application of evidence. We need to evaluate whether the application of evidence actually result in the expected outcome. So in this case, I've used a goal attainment scale because there is no specific scale available to evaluate the outcome that we are interested in, which is sitting on the floor and low stool. So we have this. I'm not going to explain much on how I've developed it. You can look into our study on squatting. More details are given. Basically, the baseline is where he has started with just -2, unable to lower self on a low chair, which is about 17 centimeter. So we have put in between milestones before he is achieving the final one, that is sitting on the floor. So the first milestone is what he has currently achieved. That is ability to lower self to sit on. It is 26 centimeter actually, not 33, with using arm support, and now he's actually in between -1 and 0, I would say, because he was able to do without arm support, and we are hoping that he will 17 centimeter he will soon achieve. Actually, in the past 2-3 days he's been doing it, is sort of able to do come to 0, but I didn't took a video recently. I was just waiting for his performance to become more consistent, right? But this is where he is in, is moving -2 to coming close to 0. I'm hopeful that he would come +1, but we will see if he is able to reach up to +2. But keep in mind, so far the outcome is more in expected or planned. What we have goal we plan, it's moving in that direction. We will have to still wait and see. Uh, right, right. So this is how the knowledge was translated into practice, and where conventional practice of uh, impairment oriented training, strength, simple isolated strength exercises was replaced with task oriented practice because the evidence suggested so. And this is how I have translated knowledge into practice. I believe this is more doable in many situations, right? If you're having more questions, you can type in the comment section, and or you can mail me in my ID, or you can post it in NeuroPhysiotherapy update Facebook page, right? We have more such episodes are coming up. Not all are evidence-based case presentation. We have different episodes are there. In next week we're going to have an interview or FAQ session with Mr. Vasantan, who's a well-known expert in upper limb rehabilitation stroke. So we're going to have a lot of questions about upper limb rehabilitation. I hope you all will join us in our next episode. Thank you everyone for listening and joining us.